We may as well get going. So I'm going to be talking about upper extremity CTA. So we obviously, for upper extremity CTA angio, we will cannulate the opposite antecubital vein. We have a certain way of doing angiography at our institution, which I'll explain in a minute, that requires a couple of mini bolus injections. The flow velocity is determined by the transit time from the aortic arch to the brachial artery. And the flow velocity then determines the table speed that we will use, and we track the first circulation of contrast. So that's just explained, and I brought this out yesterday at the meeting. The little red arrow on the timeline is the arrival time in the region of interest, which, good morning, please come in. Sorry, we just started. So I'm just explaining the acquisition technique. So the little red line is the point in the brachial artery where we have the time to peak from the mini bolus. Then separately, we will also get the time to peak to the brachial artery. The acquisition interval, you can see, starts 4 to 6 seconds after the arrival time in the brachial artery. The acquisition here is 10 seconds, and that means that we had a relatively slow flow velocity to deal with. Note, by the way, and this is a 64-channel scanner, your range of flow velocities that you can choose is actually quite wide, depending upon how you set the beam width, the pitch, and the rotation time. So it can be very slow to quite fast. We make the injection interval equal to the combination of the time between arrival and the beginning of acquisition, where we presume that we've reached a relative plateau, and then the acquisition interval. And that's a general approach that we've taken to CT angiography. When patients have slow circulations, then we can increase the acquisition interval so that the table is not moving any faster than the flow. That's in order to control the amount of contrast, and under those circumstances, we'll decrease the injection rate from 6 down to 5 down to 4, so that the total amount of contrast the patient receives is about the same. So the arm position in terms of technique can either be with, most commonly this way, with the finger separated. It can be done with the, in a neutral position with the arm by the side, and that's often in ER. Patients have had stab wounds, gunshot wounds, or significant trauma. They can't raise their arm. In that circumstance, we'll do it with the arm by the side. So here's the anatomy, and obviously we image the upper extremity from really its innominate origin here on the right side, down through the elbow, and from the elbow down to the wrist, and from the wrist into the palmar arches, and the palmar arches to the common and then proper digital vessels. It's easy to do that in people who are young adults who have good circulation. People who are older and have slower circulation, it's harder to actually image those vessels distal to the palmar arch. Here's a circumstance where the arm is by the side. This is usually an ER patient situation. Again, they can't elevate the arm. This is not as good because obviously you're including the body as well as the extremity in the CT exposure. It affects the resolution of the scan to some degree and also obviously affects patient radiation dose. We also, as we do in the lower extremities, in CT angiography, the upper extremities, we do a double pass so that we will do a first circulation down to the hand and then come back to the wrist, to the elbow, and then do a second circulation from the elbow to the wrist. And that can help when you're looking to demonstrate vessels beyond the palmar arches. So the processing, fairly straightforward. It's a standard volume-rendered MIP. Curved planar reformations are also used, and then multiplanar as necessary. So this just shows you briefly, again, this is a volume-rendered display, and then a MIP display, the MIP, which you can obviously rotate at your workstation to get the appropriate projection, and then all the way down, again, to the wrist, into the palmar arches and the common digital vessels. This, by the way, is a patient who's got an aberrant origin of the radial artery from the proximal brachial artery. That's not that uncommon. Okay, so here's a case with a supracondylar fracture, a brachial interposition graft, which I believe is right there. and a radial artery occlusion, actually from the origin of the radial artery all the way down. So this patient has a ulnar artery, I'm presuming, that's patent into the palmar arch. That actually may be incorrect. That may be the ulnar rather than the radial. But anyway, given its vessel of origin, it could well be the radial. So in any event, indications for imaging, commonly trauma, digital ischemia related to arteritis, whether that's Takayasu arteritis or giant cell, which are very occasional indications. Thromboembolism related to either something like an innominate artery disease process with thromboembolism, or post-trauma with formation of a traumatic aneurysm and thromboembolism. Dialysis malfunctions in relation to inadequate flow through the dialysis grafts, or dialysis that are associated with aneurysms at the venous onlay site. Aneurysms themselves, thoracic outlet syndrome, and then bypass graft patency. So trauma, intimal disruption, thrombosis, dissections, pseudoaneurysms, AV fistulas, the usual culprits. Here's a case which was actually a iatrogenic trauma, a patient who came to us from an attempted subclavian vein catheterization that led to this rather large aneurysm off a subclavian artery. Which was actually interestingly associated with a rather large amount of mediastinal hemorrhage and hemothorax. So not a rather urgent situation, well mapped out by the CT angiogram and the axial scan, and then subsequently treated by the placement of an endovascular graft. So that's the graft itself. Here's another case. This is actually a gunshot wound to the upper extremity. We have metallic fragment next to the artery, but this is a case where you can look at that artery, despite the presence here of some degree of artifact, fairly confidently say that we believe this is an unaffected brachial artery or axillary artery. On the opposite side of the coin, here's a patient who got a stab wound into the upper thorax, and this is a case where we believed we had a slight contour irregularity of the subclavian artery just beyond the costoclavicular space, and that probably represents intimal trauma, not something that needs to be attended to surgically, but to recognize the fact that these injuries can, in fact, be subtle. Okay, to talk about digital ischemia, Takayasu's or giant cell arteritis. Takayasu's tends to be more proximal. Giant cell, mainly involving axillary. Berger's disease can occur in the upper extremities. And then thromboembolism can cause digital ischemia related to either pseudoaneurysms, more proximal, atherothrombosis, disease of the innominate artery, or surgical graft complications, such as when surgeons do carotid subclavian bypasses and they get complications at their anastomosis sites, and the patients have thromboembolism. So here's a case of Takayasu's. Everybody is familiar with the distribution of disease, so we're able to map this out as a basically arch and neck study in combination with upper extremity. And so this patient has disease, you can see, involving, if we take it over here, subclavian, carotid, internal carotid, proximal subclavian. This is a vertebral artery origin, and that's indeed, there's more disease at that vertebral artery origin. And then here's the subclavian. And then beyond that, we have again, a focal disease process in distal axillary. Beyond that, though, the vessels actually are relatively normal. We could follow those down to the distal upper extremity. Here's, by comparison, a giant cell arteritis. This patient's had prior surgery. This is a disease that does not involve the takeoff of the vessels from the aortic arch or the proximal brachiocephalix, but it's more in the line of the distal subclavian, axillary, and brachial artery. Again, for treatment decisions, the angiogram can be actually fairly precise and show the vascular surgeons the exact extent of disease in this case. Here's a rather unusual case of a patient who has Kawasaki disease, which we recognize as something that affects coronary arteries in teenagers and young adults. But this was just an isolated aneurysm in somebody who also had Kawasaki disease affecting the coronary arteries. So the arteritis picture can be Takayasu. The giant cell arteritis, subclavian to brachial, Kawasaki disease can fall into that same distribution. And then unusual in the upper extremity, but Berger's disease can affect the brachial artery system. Here's an example of a patient who's had an aortic endovascular stent for a traumatic aortic injury that was associated with some injury to the proximal subclavian artery. And this then led to a thromboembolic event that involved the distal radial artery that's been actually well mapped out here. The ulnar artery is open. We're into the palmar arch and the common digital vessels. We've got some backflow across here into what's called the radialis indus and princeps pollicis vessels. So a very nice layout for the vascular surgeon of the extent of embolic obstruction of this radial artery. So if anything was needed to be done interventional-wise, that's actually well mapped out by this intravenous arteriogram. And again, going distally, here's a patient whose radial artery is open. You can see this on the MIP. Here it is on the von Render display. The ulnar artery is occluded in this case. And again, we got a good mapping of the digital vessels into the palmar arch, into the common digital, and even into the proper digital vessels. So for those of you who've come in a little later, the explanation as to how we're able to get this type of imaging is to do a study where the preliminary determination of flow velocity is obtained by recording arrival time in the aortic arch and arrival time in the brachial artery. That then gives you a time interval difference over from here to here that allows you to calculate the flow velocity. You then set the table speed equal to the flow velocity. You have the arrival time determined from the preliminary mini-bolus as the arrival time in the region of interest. You add 4 to 6 seconds to that so that you reach a relative plateau. Then you have your contrast traveling at a certain predetermined speed, your table following that with the same speed, following it all the way down to the fingers. Have your arm up like this, fingers spread apart if possible. Come back and do a second pass where you go from the level of the brachials down to the hand. So this is why we're able to get these types of images where you see into the palmar vessels and into those digital vessels. On this side, we've got a patient who's got a brachial artery occlusion, also has a radial artery occlusion. You can see the ulnar artery is open, and again, open into the palmar arch and into the common and proper digital vessels. And also note that these patients have their fingers out like this because we're aiming to demonstrate digital circulation, common digital, proper digital, and if your hand's like that, you don't see it. So aneurysms, we've seen a aneurysm in Kawasaki's disease related to arteritis, but aneurysms obviously associated with trauma. We'll come to this towards the end. The thoracic outlet and dialysis grafts can also be associated with aneurysms. So here's a fairly straightforward example of a patient who's got an aneurysm of a proximal brachial artery. We see it on the VR, not so well here on the MEP. But again, notice that we've actually obtained the circulation down distally. I don't believe this patient had distal ischemia, but one of the associations of aneurysms in this location can be intraaneurysmal thrombosis and thromboembolism down to the digits. This is a patient with a dialysis graft. And this patient's problem is an aneurysm on the venous side into that cephalic vein. This patient then has a cephalic vein draining into the subclavian vein. As far as the distal circulation is concerned, there's a fair amount of calcific atherosclerosis. And this is not uncommon in patients with chronic renal disease, that they will have that element of multifocal atherosclerotic disease. And on occasion, they can develop ischemic changes in their digits related to this extensive atherosclerosis. You'll also see this patient on the MIP has some calcium around the location of where the brachiocephalic conduit is. So in terms of dialysis grafts, issues can be related to stenoses at the AV fistula junction sites, stenoses in the draining vein, pseudoaneurysms at the anastomotic site, or pseudoaneurysms related to the puncture sites. Here's where you can get very nice demonstration distally, and this is two relatively young patients, one who's got an aneurysm of a palmar arch. You couldn't ask for anything better. I mean, even with a catheter and a brachial artery, you couldn't beat this. And here's a small digital AVM. Again, from the point of view of being able to demonstrate this and do mapping, this is as good as it really gets. Just going to spend a little time talking about thoracic outlet syndrome, which we relate to cervical ribs or related to fracture malunion of the ribs or a clavicle, repetitive stress per se, and post-trauma arterial injury. We're going to be concentrating mostly on these two elements here. Now, we have a CT angiographic approach to this, as Jill has asked earlier. Do we do MR? We don't, but can you use MR effectively to look at thoracic outlet? And the answer is clearly yes. So one of the things to be aware of when looking at the thoracic outlet is the anatomy. And in essence, the vessels are passing through the interscalene triangle. We'll get to show this in a minute, approximately. Then in the costoclavicular space between the clavicle and first rib, secondarily. And thirdly, behind the pectoralis minor. So here's an example where we have a volume render display here. This is a curved planar reformation. This is clavicle and first rib. And then we're looking at these tissue spaces, first of all starting out with the interscalene triangle, where the vessel runs between the scalenus anticus and scalenus medius. And in that space also closely opposed is the sum of the brachial plexus. Secondarily, then you're running between the clavicle and the first rib, and here's the artery, and here's the vein, and here's the subclavius muscle. And then thirdly, you're running out more peripherally, and here you have the, in this particular case, two arteries here at this level, and here's the pec major and pec minor, and here's the chest wall. So these CT angiographic studies are used in patients who have, quotes, repetitive stress issues. Either thoracic surgeon or vascular surgeon is using this angiographic study as a surrogate for looking for brachial plexus compression, because brachial plexus compression can occur in this space or this space, and if you demonstrate significant compression of the artery, then that's a surrogate for saying, well, maybe this brachial plexus needs to be relieved of that pressure, and that may lead to a segmental resection of the mid-first rib. So here's an example where we have a volume render display. This is the first rib. Here's, in this case, a curved planar reformation. Here we're looking at the interscalene triangle. So the medius muscle here, we've got a little bit of the scalenus anticus there. Here's the artery, which was a little bit narrowed right in that space. Then in the costoclavicular space, and this I would may well have been with the arm elevated, is really showing no compression of the subclavian artery. So is there some degree of compression of the artery at this point? Yes, it's mild. If that fits in with the clinical suspicion that maybe there is some brachial plexus compression, then surgery might be a possibility. So thoracic outlet syndromes is, again, the use of angiography to demonstrate vascular compression as a surrogate for neural compression. And we don't see the brachial plexus, but we do see the subclavian artery. We can also complement this, the arterial study with the venous study. Even when you demonstrate significant compression of the subclavian vein with the arm abducted, that's still really within the range of normal. So the subclavian vein should be looked at in patients who have thrombosis and follow up with thrombosis, but it's not really part of the evaluation of the thoracic outlet. So here's an example of a patient who's got a cervical rib. outlined here. There was significant compression of the subclavian artery at the outlet. We had the artery seen here in the region of the interscalene triangle. It was significantly compressed to occlusion in the costoclavicular space, and then we pick it up again in the retropectoralis minor space. So that's a nice positive example of arterial compression in a patient who's got a cervical rib. Here's another patient who's got a cervical rib, and notice it's really, there's a rib here, and the rib is really attached to the first rib. So there's a cervical rib come first rib combination. That led to significant compression of the subclavian artery such that the subclavian artery itself became thrombosed over time. So this is a patient who could well have thromboembolic complications as well as exercise ischemia complications of a thoracic outlet. And this patient clearly needs surgery in relation to that cervical rib. Another not uncommon situation is a clavicle fracture, which leads to malunion, and that can compress the subclavian artery. So here's a case where, again, notice we're examining with the arm abducted, because if you're doing thoracic outlets and you're looking for compression of the vessel, you really should do it with the arm like this. What we do in our practice is we have the arm abducted, the arm neutral, and then the arm abducted. We have the two comparisons. But if you look at this patient, here's the artery, which is just beyond the interscalene triangle. It doesn't really get in very easily into this costoclavicular space. The vessel is being pushed aside by this malunited clavicle fracture that we have here. So here's first rib, here's malunited clavicle fracture, and here's the vessel that's being pushed out of the way and distorted. Does that need to be corrected from the point of view of vascular compromise? Probably not. But there is some danger of this vessel over time becoming thrombosed due to the fact that it's under some degree of stress, and it's got this piece of bone sticking at it constantly over time. So thoracic outlet syndrome can result from fracture malunion. The clavicle or the first rib may be involved. It can be a cervical rib issue, or it can be repetitive stress quotes in patients who have some degree of narrowing of that interscalene triangle with exercise-induced abduction, elevation of the arm. So here's a patient who's had the surgery for this particular process, which is a resection, generally the mid-first rib. So it's a bit hard to see it here, but here's the back of the first rib, and I think here's the front of the first rib, and you can see that artery now running nicely in between those two spaces. So that's the surgical correction of a compression of the subclavian artery by releasing the pressure by the surgeon removing that mid-first rib. And that's patients examined both in the neutral position and then subsequently with abduction. Now, it's better to do a first rib resection than do what was done here. A subclavian artery stent was placed. Unfortunately, that's led to thrombosis of that subclavian artery. And I suspect that the real issue here is these stents are put under a significant amount of torsional stress when the arm is moved. And that led to this patient, unfortunately, thrombosing the subclavian artery stent. Something just unusual in terms of a subclavian artery. This is a patient who had an aberrant subclavian artery that was thrombosed proximally. And then these patients, they pick up their subclavian artery flow, in part from the vertebral artery and other collaterals. And you can see this patient's vertebral artery in part right there. So interventions, we've looked at clavicle and first rib resections, which often are very effective. Subclavian artery stent, which may have a problem with creating torsional stress on stents and creating in-stent thrombosis. In patients with proximal subclavian artery occlusions, another possibility is to do a carotid subclavian bypass. And all of these can be reevaluated postoperatively by CT angiography. Subclavian aneurysmectomy may be necessary in a patient who develops a stenosis of the subclavian artery that's associated with a poststenotic aneurysm, which can occur. In patients with venous thrombosis, the management of those patients often is, as you know, anticoagulation supplemented with angioplasty of the vein, and to some patients with venous stents, with or without a rib resection. So those patients who've had interventions throughout all these types of procedures, their post-procedure status can be well established by doing an angiographic CT, or in the case of the venous studies, we would do a ipsilateral antecubital vein injection with dilute contrast material and do a staged CT venogram. So thoracic outlet summary, remember that it's a three-compartment anatomy, that you have the interscalene triangle, then the costoclavicular space, then the retropectoralis minor space. We do arterial imaging for patients who have arterial compression, whether that's due to clavicular fractures and malunions, whether it's due to a first rib. Venous imaging is really done in patients who have venous obstruction, often patients who've had interventions with thrombolysis and angioplasty. So again, skeletal anomaly or trauma, that's, again, just reiterating the patients with cervical ribs. Repetitive stress, we've talked about that, and effort thrombosis really affects the venous side. I think we'll just push through this graft malfunction. So just to finish up in terms of upper extremities, I think it's a robust, pretty versatile technique. It's reproducible and really has replaced catheter arteriography, and you should be able to demonstrate the circulation all the way from the aortic origin of the innominate or subclavian artery all the way down to the hand and the wrist. So does anybody have any comments about upper extremity angiography? Do you use it occasionally? Any other comments upon the clinical indications? Okay.
Can I ask you a question?
Yes.
When you do the reinjection for the thoracic outlet, do you inject twice then?
Yes. I mean, for the circulation timing, indeed. So it's arrival time here and then arrival time there.
Do you need to do the complete forearm also? You can just limit the exposure to the arm, or if you're doing the second run after.
I'm sorry, the question, so we're basically determining flow velocity here. We're not really determining flow velocity here. So we may end up going faster than the circulation from the elbow distally to the wrist, which is the reason we go back and repeat and do the second pass from elbow down to hand. And again, it's important, arm up like this, fingers separated. Get the timing right, do the double pass. Okay, so in the lower extremities, we're looking at the circulation all the way from the suprarenal aorta down to the feet, aortoiliacs, femorals, or femoropopliteal, and tibioperoneals. This obviously is a normal patient, but just to show you what the objective of the study is. And the display is MIP, and then we use curved planar technique, importantly to look at the aortoiliacs, as well as the femoropopliteal. And then this again is just a schematic for the lower extremities, and the same way I explained it in the upper extremities. To do this, we determine arrival time in the suprarenal aorta. A second mini bolus will give us arrival time in the popliteal artery. You know those two arrival times, you know the distance that has been traveled, you can determine the flow velocity. Remember, this is an average flow velocity. Then we set the table speed to be equal to the flow velocity, but set our acquisition back from the point of arrival, in this case by 6 seconds, so that the contrast medium, which is now injected for the full bolus, reaches a relative plateau at about that point. And then we have the first circulation acquisition, making the contrast injection in time equal to the delay time between arrival and acquisition plus acquisition. So here we have 12 plus 6. Here's your injection interval. Contrast is put in at 5 cc per second for 18 seconds. And notice that your table speed can be varied depending upon how you set the beam width, the pitch, and the rotation time. And the table speed can be up to 11 centimeters per second. The flow velocity in older patients can be actually quite low, down to the order of 2 to 5 centimeters per second, in which case we basically decelerate the scanner to do that. And this is just showing you what happens when patients have slow circulation. We basically run the table slower, and it takes longer, but we make sure we don't outrun the bolus. So, some things about the extremities. These are figures of how common the disease is. And one of the questions I ask our residents these days, how many people in the country do you know that are living over the age of 90? And the answer is well over 3 million people. And proportionately, it's the fastest growing segment of the population. And we're going to be seeing more people with peripheral vascular disease because we're dealing with an older age population. Only about 25% of claudic patients generally will progress to a critical limb ischemia, but that's still a significant issue. And they have associated vascular disease affecting the heart and the brain. And vascular death in patients with established limb ischemia, that is physical findings of limb ischemia, 5% per annum. So the management for critical limb ischemia with the ABI less than 0.4, revascularization if possible, or if not possible, then amputation. So for non-reconstructible patients, amputation rate of 40% and mortality rate 20%. So what we're aiming to do in management of these patients with critical limb ischemia is to designate what are their potential operative corrective procedures. Can you revascularize them so that they don't get into this particular cycle leading to amputation, et cetera? So this is just to show you a patient who's had endovascular stent grafts, has had a surgical graft on this side, has had a surgical graft on this side, which became occluded, and we're demonstrating the collateral circulation via the epigastrics and circumflex iliacs and the internal pelvics that come down and reconstitute a common femoral artery, and then you've got the superficial and profunda femoral artery and some of the circumflex branches of the profunda. And you can show this either as a vascular display, you can also show it as a display with the background skeletal anatomy, which may be useful for the surgeons in getting a 3D perception of what they're dealing with. So here's this same patient. Here we are with a volume rendered display, and here we are just with a MIP display. And so we're aiming to demonstrate the graft occlusion as well as the collateral circulation and what's reconstituted and what's it look like. So here's another patient who's got diffuse calcific atherosclerosis. We're looking at the aortoiliac system, and this is the value of the curve plane technique. It really better displays the separation of contrast material from calcified plaque than you get with the MIP. And it can show you some critical stenoses. And this would be done even better, I think, with, and I don't have a demonstration of this, but you have dual energy capability of separating calcium from iodine. Now, that's rather difficult. But that would be ideal if one could have a flow lumen where you didn't have calcific plaque as adjacent to the flow lumen. Here's another case where we have aortoiliac disease, and clearly on this side, occlusion of the common iliac. And notice, you don't really see it on this BR display, but when you use the curve plane, you pick up this pretty tight stenosis at the origin of that proximal common iliac artery. So we are going to give you a topographical display with volume rendered in color, better with MIP, and then we're really looking at focal stenoses with the curved planar reformation that we use to go down the aortoiliac, go down the femoropopliteal, rotate it, get the correct projection, and really demonstrate the tight stenosis. So here's a patient who's obviously got iliac disease and has had a right to left femorofemoral prosthetic graft. And I think we displayed that pretty well. We've also got collateral circulation. We can demonstrate epigastric and circumflex iliac on the left side. On the right side, this patient's also got a femoropopliteal above knee prosthetic graft, and everything looks good. But what's happening up here is the arrow is pointing to something that we don't really see until we get the correct projection. And that's a pretty tight stenosis of the femoral artery immediately proximal to the graft. So it's very important in extremity angiography to use rotations to demonstrate stenoses that may be either overlapped by vessel superimposition or not clearly demonstrated until you get the right projection angle. So here's another case where we have multifocal stenoses on the MIP image, pretty actually nicely demonstrated here. And then here's the curved plane reformation again. The curved plane technique, by the way, is obtained by the computer doing a centerline tracking and a vessel edge detection. And so the anatomic plane is the plane of the vessel rather than basically a straight plane. But it's very useful for demonstrating these stenoses. Here's a case where we're demonstrating the circulation in the proximal calf, and this looks like the tibioperineal vessel, which is focally out. And we've got some collateral circuit. We've got a single vessel, we've got two vessels coming down to the level of the distal calf. We've got some interconnection here between them. This is probably the posterior tibial and the perineal. And then looks as though we have a posterior tibial maybe coming off a calcaneal branch here into the plantar arch. But the essence of the process is we want to demonstrate flow distally into the foot. Not as nicely as you can get with a catheter, but sufficient for surgical planning or endovascular planning to be done. Here's a patient who had the blue toe syndrome. So all the circulation distal to this particular site here looked normal. The patient was in his early 30s, but it wasn't until, again, we used a curved plane technique, appropriate rotational angle, and then we could see this patient had an ulcerated atherosclerotic plaque in his mid-30s in his proximal common iliac artery that had thromboembolized down to his toes. So that's the value of the technique in being interactive in the workstation, rotating, clearly demonstrating where the pathology is. So thromboembolism, we just saw a case in the iliac arteries. It can come from the thoracoabdominal aorta when we have significant atherosclerotic plaque. And its presentation actually can be relatively acute, the blue toe syndrome. Thromboembolism, where this is more, not just sort of atherosclerotic material, but arterial thrombotic material can come from the heart, the thoracoabdominal aorta, come from the iliofemoral system, even come from the popliteal. So acute unilateral symptoms. So here's an example of a patient who has a fairly acute popliteal artery occlusion, which you can see down here. But it wasn't until we really looked back at the aortic contour on a curved plane appropriately rotated that we picked up this patient has a large thrombosed or partly thrombosed aortic aneurysm. So thrombosed or partly thrombosed aortic aneurysms are not an uncommon cause of having distal thromboembolism. This is just an example. And again, the use of the technique to really lay out all the anatomy and pathology very precisely. So this patient clearly needs an embolectomy, which is done immediately following this type of CT angiogram. So here's another patient who's got aortoiliac disease, but it's aneurysmal. And the point here being that there is an aneurysm of the subrenal aorta, but there's an aneurysm of the common femoral arteries. And I wouldn't be surprised, yes, we have aneurysms of the popliteal arteries in this patient bilaterally. And this patient has had a popliteal artery stent placed on that left side for treatment of aneurysmal disease. So these patients, patients with aortic aneurysms, they have symptomatic limb ischemia, will preoperatively have an evaluation of the lower extremity vasculature. Or people with aortic aneurysms are evaluated clinically and by Doppler for the possibility of popliteal artery aneurysms, and if they have those, then we proceed to do full deck lower extremity CT angiography. So this is showing you this patient with a long segment stent in the popliteal artery. Looks as though what is being demonstrated here is that the stent may have ended around about this level, and below the level of the stent, then we have a persistent, partly thrombosed popliteal artery aneurysm that's being measured on the axial plane, giving its true dimensions, both AP and lateral. The problem of putting a stent into a popliteal artery that traverses the knee joint is that that's going to undergo a lot of stress due to knee flexion, and that can cause disruptions in the stents. It's the same issue with the subclavian artery stent, that the thoracic outlet, constant motion, will create distortions of that stent. So here's another example of a popliteal artery aneurysm. This, I think, was an acute trauma event. You can see there's quite a disruption here of the distal popliteal artery, partly thrombosed, rather prominent popliteal artery aneurysm. So peripheral arterial aneurysms in association with abdominal aortic aneurysms, femoral aneurysms are actually quite common. They're not necessarily large. And I think we're all familiar with the fact that popliteal artery aneurysms can be a pretty common association. The presentation is of these aneurysms, pulsatile swellings, or remember, thromboembolism. So here's an example of an aneurysm of the femoral artery. And importantly, I think this is a post-trauma case and post-cath. What we also demonstrated in this case was an arteriovenous fistula. And that, of course, obviously is important in terms of management here. You don't want to do aneurysmal thrombosis in a patient with an AV fistula. So here's another example of a patient who's got an aneurysm. I think this patient's aneurysm formed at the upper aspect of a femoropopliteal above knee graft. And again, here we're seeing the aneurysm itself. Here's the more proximal popliteal artery. This is a curved plane reformation that's following the aortoiliac system down to the level of the femoral. So additional causes of lower limb ischemia, apart from atherosclerosis and athero and thromboembolism, arteritis, trauma, dissections, vasospasms. This is popliteal artery entrapment syndrome or adventitial cystic disease. I think I'm just going to probably just show you this one case and we'll finish because we're getting pretty close to time here. But this was an interesting case. It was a young boy under the age of 10. And he's got narrowings of his common iliac artery on the right and the left, particularly on the left. Here we are again, both common iliacs. And here's the curved plane reformation showing you that very narrow vessel. And there was soft tissue thickening around this. And this is a case of Tachyashu's, which is very uncommon in a young pediatric patient who subsequently developed Tachyashu's in his subclavian artery. This is a young lady in her mid-30s, unfortunately very obese, heavy smoker, who's got Berger's disease with the distal femoral popliteal artery occlusions and some reconstitution of flow into both calves. And then just as a final example, here's a patient who's got a dissecting aneurysm of the common iliac artery on this right side, again, clearly portrayed by the curved plane reformation as well as the volume rendered display. And I think this dissection actually began in the subrenal aorta, where you can see the proximal aspect of the false lumen. We've had about 5 or 6 or 7 patients who've had spontaneous dissections without known cause of their aortoiliac system, who've had dissections but have not manifested ischemia, though these people are obviously likely or possible to get thrombi and thromboembolism run these. Well, with that, I know we've hit 12 o'clock. I've covered a lot of territory. Thanks very much for all your attention.